Y'all, it's all over CNN, BBC, LBC, all the major news networks. Have you heard of it? It's Reza and maybe Robbie sometimes. YouTube. Let me show you. This guy, Prof. Rez, who can't interrupt me because he's eating right now, it's glorious, is gonna change. You're gonna see my YouTube algorithm now, by the way. It's gonna change your life. Look at this. Formula One highlights. Arsenal versus Tottenham. And what? Look at that. Um, I highly, highly, highly recommend you check this out. Not only is it, of course, cutting edge teaching skills from the one and only Prof. Rez, but the guy went from an absolute amateur to like essentially, in my opinion, professional. In most of your opinions, probably semi-professional uh, at making high quality videos. It's unreal. If you don't know how to access this from my YouTube channel, all you do is go to our main website, and now you find it here or on our YouTube. Check it out. You will not regret it at all. Um, while I'm telling you about all the incredible things that are happening in the CP solvers world, I will also tell you about two really cool things real quick since we're here. The first is Search CPS. It's an incredible tool developed by one of our team members, Saket, which allows you to I'm trying to figure out where, yeah, um, which allows you to search through all the transcripts of VMR and learn in a targeted, efficient way. So if you want to say Reza abdominal pain, watch this. You can see, oh, look at that big smile. Look, my wife is here too. Um, but this will take you to all the times Reza has uttered the word abdominal pain and to teach you every single time he's thought about it. And the truth is, I'm still a novice in this skill set. There's a lot that you can do, including this new feature that I just noticed, which where you can see the whiteboard of that case. So this is really, really, really cool. Um, it's also a great time to tell you all about the CP Solvers Academy. The CP Solvers Academy is all the people behind the scenes who are making all of this stuff happen. And the only difference between you, if you're not a member, and them is just how regularly you join VMR. All are welcome, literally, all across the world. And these are all the people you see. We really, really want you to be just like them, be part of the family. And so come hang out with us on VMR, present cases. And you too will be like Sam, Lyra, and Nicola, who are making things happen today. You will also have the benefit of being part of our internal sessions. And as the clock hit 9 here, Lyra and Nicola, our case presenter and teaching points people, were presenting a case to each other of an incredible journey of a young woman with a hydropneumothorax. And if I spent time talking about that case, we'll deviate from the goal today. But thank you guys for that incredible session. And I'll hand the mic to you in a moment to say hello and to kickstart. But would love to hand the mic to our scribe today, Sam, to kick us off, and then Lyra, and then Nicola.
Hi, everyone. It's so great to see you. Great to be here for another very exciting case, which I hope you will all enjoy Nicola's presentation. It's a beautiful day here. Um, I hope you're all having a good day.
You're not going to rub it in that you're enjoying the main summer sun. That's very, very kind of you. We're very, very
I mean,
jealous.
I already rubbed it in. It's okay.
True that. I hope you get to enjoy it today too. Lyra, what have you been up to today?
Yeah, hi everyone. I just presented a very cool case to Nicola, and he's been telling me about the slides that he prepared for today's session, so can't wait to see them.
Amazing. My guess is going to be GPA, 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 just based on sheer luck. Incredible. Nicola, how have you been?
Hello, hello, my dear friends. Yeah, I'm still a bit tachycardic from Lyra's amazing case. It was such a doozy, and I can't wait to look up to date a few things uh, after the session. I brought for you a really interesting case. I hope you'll also find it as intriguing as I did. It's a case that was presented to me. I was not involved with directly taking care of the patient, but I think it's a very rich one from which we can all learn a lot.
Incredible, incredible. Mission accomplished, guys. We heard from each of you. We got to plug the YouTube channel, the Academy, and I think Prof. Rez has now inhaled his sandwich and ready to go. Is that good, Prof. Rez? Awesome. All right. Nicola, take it away, my friend.
Okay, my friends. So you're stepping into the ED, and there you find a 62-year-old male who is presenting to you due to dyspnea that began suddenly as he was walking upstairs in his home. And I'll stop right there. I have 6 aliquots in total, and then the final diagnosis.
Um, first of all, good morning to everyone. Thank you for letting me eat my burrito. Can we just take a minute to recognize how incredible of a leader Robbie is? He's literally post-call, elevates everyone, and it's just incredible to see all the things that CP Solvers is doing. Really, really cool, Robbie. That's like, gave me goosebumps, man. That's really awesome. So now talking about the case, Nicola, I'll be very brief here because we're going to need much more information before we can like really frame the problem. But there's one key word that maybe if you search in that incredible engine that they created, Search CPS, what would that keyword be in all of this? There's just one keyword that has grabbed my attention. Curious to know what the chat thinks and what our beloved YouTube people think. Yeah, Elena said burrito. Yes, Maddie, spot on. Sudden onset. You know, we've highlighted this many times before, like tempo is queen in clinical reasoning. And when something suddenly happens and the patient can recollect the time, it's most likely a dramatic, sinister process. And when you link sudden with dyspnea, you start thinking about stuff like clot formation, whether it's in the pulmonary vessel or whether it's in the coronary vessel, ACS or PE. You think about vessels dissecting, like an aortic dissection, and a patient like this really needs to be urgently evaluated. We'll be able to make more progress once we get a lay of the land and we look at chest x-ray and stuff like that. But anytime you hear that word sudden, think some kind of acute vascular catastrophe, though that may change as we get more. I'm gonna give the mic back to Nicola because we have so many more aliquots to come, and we're gonna keep Robbie on a little bit of a control.
Okay, my
Wait,
friends.
Nicola, when Robbie does this, that means he's just itching to say something. The hands go around the mouth. He does this, and then people complain that they can't hear him, but he ignores them as always. But I knew he was thinking of something, but he'll say it in aliquot too.
I almost said, wow, that was so brief and concise, Prof. Rez, but unfortunately, I have to take it back now.
All right, my friends. So Reza wanted more information, and I have quite a few information for you. So to give you more a history of presenting illness, so the patient reports that over the last few years, and more recently in the last 6 months, he was feeling sort of under the weather, complaining of fatigue, weakness, also some mild abdominal pain, and a nasty sort of dry cough. Recently, he felt like he would get more easily out of breath, more easily than usual, especially when climbing stairs. But he attributed this to his age. However, today, while walking up the stairs in his home, he felt a sudden sharp pain in his chest. The pain is worse when he breathes in, does not change in position when he changes position, does not radiate anywhere, and cannot be triggered on palpation. On questioning, he reports some mild weight loss over the last month. The review of systems is negative for night sweats, rigors, fever, myalgias, syncopes, nausea, vomiting, or diarrhea. As for the past medical history, it's significant for arterial hypertension, hyperlipidemia. The patient also suffered from 3 venous thromboembolic events over the last 5 years, 1 DVT, at his age, at 57 years, so like 5 years ago. Then a segmental PE when he was 59, and then a portal vein thrombosis at 61, so last year, basically. He has no autoimmune disease history, no recent surgery or trauma, and he's up to date with his age-appropriate cancer screening. As for the medications, he's on apixaban, and he reports good adherence. He also takes atorvastatin, amlodipine. He also takes some multivitamins, which he doesn't really specify. There's no allergies. As for the family history, his father died of an MI in his 70s. His mother died of old age in her 80s. Social history, he's an accountant, lives in an apartment with his wife and 2 kids, all of which are healthy. His last travel was 3 years ago when he visited Peru with his family for vacation. He reports no sick contacts, no animal exposure, no tick bites. He reports on having a monogamous relationship with his wife, and he drinks around 1 beer per week and has a 20-pack year history and is a current smoker.
Nicola, you brought back a very powerful childhood memory for me. I remember when I was starting to get interested in medicine, this tells you how crazy I am. I sat down with my mom and asked her about all our family members and how they died and what they died from to like understand our family history. And I can't tell you how disappointed I was in her answers because almost every single time she said 2 words, old age. I was like, what? And it goes to show you, it goes to show you, well, my family is from a very small town in a mountainous region of Lebanon where diagnostic clarity beyond old age was hard to attain. So, uh, anyway, that's not neither here nor there. I may progress. Maybe I can take the HPI, and I'll leave the rest of the medical history with you. And yes, I know what you're thinking. I need more sleep. It's definitely true. So the HPI is fascinating, and I think teaches us a really important lesson. If you go back and you revisit what Prof. Rez said about sudden onset being a vascular problem and being uh, uh, um, uh, potentially a risk factor for a patient developing pulmonary embolism or a patient developing coronary artery disease, let's just use coronary artery disease as an example of that. So when somebody develops acute onset disease in the chest and their coronaries, we call that acute coronary syndrome. And acute coronary syndrome doesn't go from 0 to 100 in 1 second. The vast majority of acute coronary syndrome is laid upon a pre-existing, either clinically evident or clinically silent plaque. In other words, acute coronary syndrome is not purely an acute disease. It's an acute on chronic disease. Virtually every single patient with sudden onset hyperacute disease has a vulnerability that caused them to get so sick so quickly. In other words, it is very, very, very unusual for the human body to get that sick that quickly without having a predisposition. If you develop a pneumothorax suddenly, your bleb is the reason why, and your bleb didn't develop suddenly. If you develop a pulmonary embolism suddenly, your DVT didn't develop suddenly. It was there for a while. And so I think that what's happening here is that Nicola is telling us that the patient's vulnerability was clinically evident. He had fatigue, weakness, abdominal pain, dry cough, weight loss, and exertional shortness of breath. And those are likely painting the picture of why the patient was walking closer and closer to the edge that ultimately culminated in the sudden presentation today. And so why am I saying this so thoughtfully is because most of the time when somebody comes in with sudden onset blank, we move as quickly as the disease is moving because our reflexes are triggered to be a little bit less thoughtful about the background. I cannot tell you how powerful it is to ask somebody with chest pain, not more about the nature of their pain now, but to ask them what they were like before the pain began and how much they could exert themselves. So if I'm trying to rule out ACS and somebody tells me 2 days ago I ran a marathon, it's very different than somebody telling me 2 days ago I could walk and I get a little bit of shortness of breath. None of those patients, I'm asking them about what's happening now, but that question has profound implications for what's happening. And in this patient, I worry a lot because the not only is the HPI rich with preceding information, but the medical history is rich with risk factors for the same, which I'll leave to Prof to dissect. The only thing to make more out of the chest pain is that it is in fact pleuritic. And pleuritic chest pain reflexively often means that the pleura or the pericardium is irritated. And you would be able to make tremendous progress in real life is if you were able to establish if it's central pleuritic chest pain, meaning in the middle of the chest, or if it's lateralizing pleuritic chest pain. So I don't know, Nicola, do you happen to know if the patient's chest pain was on one side or both sides or in the middle, or is that not available to us today?
It's a unilateral chest pain.
Yeah. And so the unilaterality here is very, very concerning for a pleural process. And the pleural process here would be either ischemia of the pleura, infarction, rupture of lung into the pleura, so a pneumothorax, or a hydropneumothorax. But what does this mean when somebody says develops abrupt onset pleuritic chest pain? It means that if you don't get an answer with an X-ray showing air, you immediately need to go to a CT scan with contrast. So if I'm hearing this history, abrupt onset unilateral pleuritic chest pain, I'm going to get an X-ray in 2 minutes to see if there's air. And if there is air, I now have my problem. It's a pneumothorax. If there is no air, this is a pleural infarction or PE until proven otherwise, and the patient should get a CTPE even without the rich history that we have. So maybe Prof. Rez, I can hand the mic to you to tell us more what you're thinking of that.
Man, that's so rich, Robbie. I know you just worked an overnight shift, but I just have a question. I'm curious, like as an ED provider, you know, when we're considering aortic dissection, PE, like both are on our differential, do you end up getting a CT with contrast? Or in this case, do you actually go for the CT PE protocol? And I just don't know how much you lose by just doing a CT with contrast if it's a significant clot and getting both aorta and pulmonary vascular.
Prof. Rez, it's like not only is it an outstanding question in general, but I think it has tremendous implications for this patient too. So I think if you're considering aortic dissection and pulmonary embolism, aortic dissection laughs at a pulmonary embolism in terms of its morbidity and mortality, really. So many people have PEs. 85% of people with pulmonary embolism have low risk PEs and do just fine. Aortic dissection is a universally deadly disease untreated. So if you're stalking and comparing the two in terms of morbidity, who cares about a PE if you're seriously entertaining aortic dissection? But the problem is that the vast majority of times you're suspicious of both diagnoses, the relative probability of your suspicion is strongly weighted towards a pulmonary embolism. So the truth is that even though you hold aortic dissection in the back of your mind, realistically speaking, you're much more worried about PE based on probability and base rate. And so I think how we settle the tension is to recognize that if you prioritize prioritize contrast for the aorta, you will be able to, in the vast majority of instances, see the main pulmonary artery and the right and left main trunks. So you'll be able to see a visible large filling defect. What would I do in this patient? I think that this is the kind of patient where you actually need the contrast to go all the way down to the small arteries. The reason I say that is this patient is presenting with what sounds like, if it's a PE, what sounds like pleural infarction or lung infarction. And in those patients, the vast majority of them actually have pulmonary emboli in their small distal pulmonary arteries. They're so small that there's no collateral to reperfuse the now ischemic injured lung. So in this patient in particular, I would forego the aortic dissection protocol because the pretest probability of aortic dissection is lower so far, And I really need to visualize the distal pulmonary arteries, given the presentation of what seems to be a pleural parenchymal infarct, if it is. So that's how I tackle it. I'm curious what your approach is.
Oh man, I was just really wanting your approach, like as like an ED provider. But I'm not, I don't find myself in that situation often, to be frank. So thank you for that. I love that approach. Uh, and I'll keep my discussion brief. I have to say, like what we're seeing here is a lot of thought. And Nicola said something that like really made me think of like how precise he is in medicine and what the CP solvers community is. He said arterial hypertension. And I was like, wow, yeah, that's such a precise term as opposed to like venous hypertension. And I want to take a page from Nicola's book and say there are clots, but I want to categorize them as venous or arterial. And here we're seeing all these clots are in the venous system. Because if you end up putting that frame of venous plus arterial, all of a sudden the differential diagnosis narrows significantly to the potential culprits. But I think once you have more than one clot, it's safe to say that you're dealing with the ultra hypercoagulable state. And here we have a clot in the mesentery. The most common cause of portal vein thrombosis is underlying cirrhosis. But any kind of inflammatory process within the abdomen can lead to clot formation, or if you just have a hypercoagulable state that ends up causing clots everywhere. And I think that's another important point to make. You can even make more progress. Like we said, arterial versus venous. When you're venous, you could say, oh, is it classic in the lower extremities where most DVTs form? Or is it in a unique place? Is it a cerebral vein thrombosis? Is it Budd-Chiari syndrome? Like those ends up being unique clots, and those may help tip the differential diagnosis. And then something else that we're contending with here is that this patient's on apixaban. So how can you have a PE on apixaban? That doesn't make much sense. Well, there's a few possibilities. One, he's not taking the apixaban. And you always have to be open to that, but you don't start and finish with that thought. That's always at the end. Another possibility is that he is taking the apixaban, but maybe the reason he's clotting is not susceptible to apixaban therapy. And you can think of an example like antiphospholipid syndrome. This is going to be a little more higher level, but if you have antiphospholipid syndrome and you have more than one serologic marker, you should be on Coumadin based on the data that's out there. If you have a single marker, like let's say the lupus anticoagulant is positive, but the phospholipid antibodies and beta-2 glycoprotein, I always confuse that with microglobulin, and you know when you're in front of someone that you admire and you're like trying to, not flex, but trying to speak medicine, I was like, yeah, this patient's APLS beta-2 microglobulin. And then the other guy was like, that's the marker we sent for myeloma. I was like, oh, I mean glycoprotein. But if this is more than one hit APLS, that's the way he can clot, or that he's just so hypercoagulable that it doesn't matter that the patient's on anticoagulation. But regardless, I think the CT scan is going to be really helpful, PE protocol. I just want to say that like what I'm activating here is just an ultra hypercoagulable schema. And that can be from stuff like inherited cause of clots, but the stuff that you learn in medical school, like protein C, S, factor V, vitamin mutation, they don't really cause that much hypercoagulability unless you have multiple hits. The most hypercoagulable state in that sort of area is antiphospholipid syndrome, but then you have stuff like malignancy, but that doesn't, I don't like the malignancy hypothesis because the clots are happening over time and the patient isn't completely devastated. So I think, Nicola, we're ready for the physical exam. And depending on how we frame this problem, we may apply the background data differently through a new filter or lens.
Absolutely brilliant. The discussion points have already been touched upon. So let me give you now the exam. So in front of you, you see a middle-aged male lying down on the gurney in visible distress. As for his vitals, he has a heart rate of 110. His BP is 135/98. You count around 20 respirations per minute. His temperature is around 100 Fahrenheit or 37.8 degrees Celsius, and he's setting 93% on room air. As for the HENT exam, there's some conjunctival rim pallor. There's no signs of jaundice of the sclera, and the airway is free. Cardiovascularly, you hear the tachycardia, there's a normal rhythm, no murmurs. On the pulm exam, you see that the patient is tachypnic. There's some crackles bilaterally, but those clear after you ask the patient to cough. The abdomen is not distended, but it's tender to palpation in the epigastric region. The extremities are warm to touch, not clammy. There's no rashes. And neurologically, he's oriented ×4. And I also have for you an ECG, which I sent to Sam. So Sam, if you could maybe, oh yeah.
Dr. Zhao, maybe I can take a crack at this because I don't often do EKGs. Well, I mean, I do EKGs, but then you can comment on everything else and my read on this. You know, they'll teach you in medical school this sort of formulaic way to approach electrocardiogram. That's not wrong as you're getting started. But if you think about it, this patient's coming to the ED, sudden onset shortness of breath, history of multiple clots. I'm just really looking for any catastrophic findings on an EKG. And really, I'm just trying to assess 3 parameters. One is the complex narrow wide. Here it's narrow. Is it regular or irregular? I can clearly see a regular rhythm with nice P waves. And then the third is now looking for any kind of ST segment abnormality. And in order to be able to tell the ST segments, you really got to learn how to identify the isoelectric line. And I'm sure this grabbed everyone's attention. Like, yeah, take that cursor to V1. Right away, you see, look at that ST segment in V1, come down to V2, come down to V3. Like, these are abnormal segments. And like what my mind is trying to do right now is it's trying to tell, is this, there's definitely some ST segment elevation and there's some deep T waves. So immediately I'm looking, is there anywhere else that has ST segment depression? Because by definition, if someone is having a STEMI, and by the way, the morphology also matters. That looks like a tombstone almost. So it's not as elevated, but you have to understand the natural progression of someone with ACS. It will go through an evolution where you'll end up with the inverted T wave. So I'm looking, that's in the anterior leads. I'm looking in the inferior leads now, 2, 3, and ADF. I see T wave inversions in lead 3 and in ADF. The ST segments don't seem significantly depressed, but what this EKG does for me, Robbie and Nicola, it really makes me worried that there is something going on at the level of either the coronary vessels or some kind of vascular catastrophe. So what would I do with this EKG? I wouldn't stop there. I would get troponins for sure, and then I would keep repeating the EKG to see if there's any dynamic changes. This doesn't strike me, Robbie, as like the deep inverted T waves or the biphasic T waves of Wellens, because that initial point, it just seems like the ST segment is odd. But I'm just curious, what do you think, my friend?
Prof. Rez, I'm going to show you something because this is amazing EKG. I'm right there with you. The first thing that grabbed my mind is the, like, not quite Wellens, but Wellens like. I don't want to recapture you, but then I was like, wait, is this pseudo Wellens? So here, check this out. The Wellens patterning is not specific to Wellens syndrome and may represent other conditions. Pulmonary embolism. Scrutinize the inferior leads for clues, especially in lead 3 and V1. And there's a really nice tweet that you can look at. So that's exactly what I started to do. So if we go to Nicola's fantastic EKG, let's scrutinize the inferior leads, okay? We got the Wellens vibe. There's T-wave inversion in the anterior leads, chest pain. You scrutinize the inferior leads. What do you see? I see Q-wave in 3 and T-wave inversion in 3. And so, that's my trigger. Is this a pulmonary embolism? Then I look at 1. There's a deep S wave in 1. So S1, Q3, T3. Where does that take me? I know you've actually taught a lot about this, Prof. Rez, S1, Q3, T3. I think nobody teaches it better than you. But yeah, I went to Wellens like, and then because I've missed this before, have my checklist for pseudo Wellens, and I think we might hit that checklist here with the S1, Q3, T3. What do you think of that?
I love it. Was it Supreti? Who was the CP Solvers VMR team member that brought this EKG? And then you showed it to me. I wasn't even in the session. I
Yeah.
had a little bit of flat. I was like, oh man, it was Supreti?
Yes.
Yeah, yeah, absolutely, man. And that whole S1, Q3, T3 is good for RV strain, but it's not good for PE, meaning the likelihood ratio is just 1. So it doesn't really raise the probability of a pulmonary embolus, but it does raise the probability of RV strain. Yeah, I remember Supreti. That's awesome, man, that we're seeing this again. It repeats itself, huh?
100%, Prof. Rez. And I think this is just like the power of not getting overly attached to what the S1, not getting overly attached to anything really, and just going back to what the patient said. He said, hey, I got abrupt onset right right-sided pleuric chest pain. There's only really 2 possibilities here. And once you don't hear air on the lung exam, this person is going to the CT scanner. And now you're just building more and more reasons for why this person is going to the CT scanner, let alone his history, which you emphasize. But now you see that he has evidence of right heart strain. We don't know if this is chronic right heart strain, acute on chronic right heart strain, or acute right heart strain. We don't know that. But we can hem and haw, and I think in internal medicine sometimes we hem and haw too much. This EKG just adds to the list that's already ballooning. He needs a CT. Yeah, I don't want to. I think Nicola wants us to discuss the rest of the data, so why don't we? Unless you had more to share in this aliquot, Nicola.
No, that's pretty much it, and you dissected the ECG perfectly, so I wouldn't even dwell on it further because you basically interpreted it as the same as my notes. So I can give you guys the labs.
Nicola, can I
And
just to say real quick because I think we left it on the table, and I'll ask Prof. Rez to take the next aliquot to some Emily. I think we should put a pin in the fever. It's an interesting element here. I wasn't expecting that, a low-grade fever. It's not technically a fever, but it's interesting. And then whenever you have somebody who you're worried about PE and they're tachycardic, you should be thinking 5 steps ahead. Vast majority of patients with a pulmonary embolism are not tachycardic, even though that's what you've been taught in medical school. That's because the vast majority of patients do not have a PE significant enough to need to be tachycardic. So if I'm seeing this in real life, I am calling the pharmacy and letting them know, hey, I think I have either a high risk or intermediate risk pulmonary embolism. And I would begin to call what we have here in our system a PE response team. And I'm saying all that not to give you the details of what would happen in my hospital, but to say that when you're worried about PE and you see these vital signs, the patient could crump on you 2 minutes from now, especially when we know that he just got sick. Like he just got very, very sick very quickly. So we don't know what the next hour or 2 are like. And so be very, very ready for this patient to get very sick very quickly, even though the blood pressure is normal now. All right, what do you have next, Steve?
just amazing listening to you guys talk. So a bit more information. I have the labs and I have the imaging that you both really wanted to have. So hemoglobin of 9.0 with an MCV of 71. Platelets of 74. The blood cell count is at 7.8 with a neutrophilic predominance, no eosinophilia or basophilia. The creatinine is at 1.0. The BUN is at 37. AST, ALT, alkalic phosphatase, and gamma GT are all normal, as are the PT and the APTT. The LDH is at 560, with the upper normal limit being around 250. Heptoglobin is normal. D-dimer is at 2.6, with the upper normal limit being 0.5. Protein levels are at 8.3, with albumin at 3.4. CRP is at 20, the ESR is at 40, the ferritin is low at 18, the soluble transferrin receptor is elevated at 3.9. There's also some high sensitivity troponin at 19, with the upper normal limit being 14. And NT-proBNP is also slightly elevated at 350, with the upper normal limit being 240. On echo, there seems to be no right ventricular dysfunction. And I also have the CTPA, which shows actually bilateral segmental PEs. The heart appears normal, the lung parenchyma appears normal, there's no lymphadenopathy or any other lesions. They also did a duplex ultrasound of the legs, and I actually did found an acute DVT of the left leg, which was actually the same leg that was affected all those, I think, 5 years ago. And let me stop there.
Wow, this case is so juicy. Nicola, can I ask for one more lab value? Do you have a PTT, or are you hanging on to that?
The PTT is at 35, which is basically the upper normal limit, 35
Okay,
seconds.
perfect, perfect. You know, it's so fascinating. And how many of you guys, we saw the power, we knew the patient's hemoglobin would be less than 10. And when you try to overlap clot with anemia, not through like a cancer in the GI tract, it made me think immediately of hemolysis, specifically TTP-HUS. Like that's where my mind went. And that exists on a spectrum. But then and this is the power of like really understanding medicine. Then I looked at the MCV before Nicola gave any other data. And I was like, well, if someone's hemolyzing and they're making reticulocytes, the MCV is actually large. It's like 100 and, I don't know, 20 or something like that. So the MCV usually averages out to about 100. And that was a strong clue against hemolysis and a very strong clue towards the number one cause of microcytic anemia. And did you ever wonder why people actually get microcytic with iron deficiency and fear the ferritin being 18? You've clinched that this patient has iron deficiency anemia, which is a proximal diagnosis, not a terminal. So you have to ask the question, why do they have iron deficiency anemia? But iron is an important building block of hemoglobin. And hemoglobin is what gives the mass of the red blood cell. So if you don't have iron, you don't have good functional hemoglobin, then the red blood cells, they look small and they start shrinking inside. And that's how you get microcytosis. But something else that grabbed my attention, which was really cool, was the platelet count. Like how many people are clotting like this with thrombocytopenia? So that even if you don't have a DBX because think about it, what do platelets do? Platelets help form clot. Here the platelets are low and the patient is clotting. Even if you don't have a differential diagnosis for that, just recognizing that pattern, oh, that's a little odd. Why is the patient thrombocytopenic and having devastating clots? A quick way to explain that, we already talked about like TTP-HUS and how they can develop thrombosis and have thrombocytopenia. But another really nice explanation would be antiphospholipid syndrome. And not that the antiphospholipid syndrome would explain the iron deficiency, not to my knowledge. So I'm still wondering why this 62-year-old guy has iron deficiency. And since that prompted in my head, I'm like, did they ever have a stroke? Because the number one place we look for is the gastrointestinal tract. before looking elsewhere. And then you look at the LDH, and the LDH is not lying, it's 560, but it's not because the red blood cells are hemolyzing. It's either because of Rabih's initial hypothesis that the PE has now caused infarction, and that infarction is what's causing this high LDH. So usually the pulmonologists are really good at telling you that there's infarction. Thank you so much. That's because I'm discussing it so well, I'm getting a coffee, so I appreciate that. There's infarction, but if I would ask and see if there's no infarction, then I would step back and be like, why is the LDH so high? And we've already ruled out the most common cause hemolysis. Then you start going down that pyramid of LDH, and you're like, oh, is there some underlying malignancy that's causing this high LDH? So I think for this patient, Rabih, the strongest problem representation is a middle-aged man, history of recurrent venous clots while taking apixaban, who's presenting with bilateral segmental PEs in the context of thrombocytopenia. I can't reconcile the iron deficiency yet, and maybe there's something I'll learn from you, Rabih, or the group, but I think what my next step would be prioritizing APLS, and then second to that, looking for underlying malignancy, because you could have DIC, for example, and have thrombocytopenia, and the patient is slightly inflamed. That can lead to both thrombocytopenia and clot, but to have like DIC explain all this history doesn't make sense to me. So my mind is fixated on APLS, to be honest. And that's why I asked about the PTT, because it's a hypercoagulable condition, but the phospholipids interfere with the PTT assay, making you appear coagulopathic, though in reality, you're hypercoagulable. But I would love, Rabih, for you to comment on this.
Yeah, Prof. Rez, I love your analysis, and the truth is I'm right there with you. Yesterday's case, Prof. Rez, was a case of I'll spoil it, whatever. If you haven't listened to yesterday's case, pause and go back to it. It was a case of Behçet's, Prof. Rez, a tragic case, 40-year-old man in New Jersey who had ultra hypercoagulability. So we're getting space rep this week in ultra hypercoagulability, and ultimately there was no clue as to why he was having all these clots, and ultimately a good review of systems found that he had oral and genital ulcers, and that's how they figured it out. And so yesterday we were talking about how when you're thinking about ultra hypercoagulability, a very simplistic way of trying to figure it out is do you have a purely do you have a pure clot disease, or do you have clot disease plus extravascular clues? So yesterday, the only way the case was solved was the patient had extravascular clues ulcers. And I would venture to guess, because I can definitely read your mind, Prof. Rez, that you're so focused on APLS because it is a pure intravascular disease, and this patient has little to no extravascular clue. And I think if you were to tell me what is the most common hypercoagulable condition that has little to no features outside of clotting, it's APLS. And especially in a man where you cannot use recurrent pregnancy loss as a clue to suspect it, that's all you're left with in most instances. So I think that's probably why it's front and center. And so the question for all of us is, are there any extravascular clues here? And I don't think so. The question that you're postulating, Prof. Rez, is using the LDH and saying, is the LDH a sign of an extravascular malignancy, which I think is a beautiful question. And I'm struggling with that same question, and also struggling with what the significance of iron deficiency here is. And this is it's so helpful now to be PGY 11 and to have experienced real life, because at PGY 5 I would have been like, oh my gosh, iron deficiency in this situation, it's so rare, it must be a clue. Every person I saw in the last week who was on apixaban is iron deficient. They all ooze in their GI tract, especially when they're over 50. AVMs, little gastric ulcers. And now I've gone from PGY 5, ooh, iron deficiency, so interesting, to PGY 11, iron deficiency on apixaban, predictable. So the question is it signal or is it noise? And I think the reality is, in most of the time, it's complete noise. But if we're going to potentially use it as signal, it sets up an interesting conundrum, Prof. Rez, because it tells us that the patient is clotting, which we know, but also bleeding at the same time, right? Because the vast majority of iron deficiency is bleeding, often in the GI tract, but also in other places. So if we use that to our advantage and say, hey, actually, this is an extra clot signature, I should say. Vascular probably isn't a good word, is there? Extra clot signature. And the answer may be yes, the patient has a high LDH. It also may be yes, the patient is bleeding. Where? Could this be a GI tumor? I think it's possible, but the time course of 5 to 6 years is less in keeping with it. So is the patient bleeding elsewhere? Are they bleeding in their lungs? No. Are they bleeding in their skin? No. Are they bleeding in their urine? Maybe. And I think that's where PNH enters the calculus a little bit here. And that's the kind of esoteric thought I had. I'm almost ashamed I had it, to be honest with you, Prof. Rez, because it's getting too much juice out of the information we have. Realistically speaking, iron deficiency anemia is noise here. It's chronic GI blood loss from the anticoagulation. But if you're putting on your CPS hat and you see iron deficiency anemia in the context of a thrombotic condition, PNH deserves some mention, especially if the patient has symptoms suggestive of nitrous oxide consumption. So PNH in the hemolytic phase of PNH, you get iron loss, intravascular bleeding, and iron loss through the kidney. And you consume nitrous oxide. So patients get a lot of smooth muscle dysfunction symptoms, including vague abdominal pain, a dry cough, dysphagia, so on and so forth. So would I test for PNH in real life? Not yet. No, I think it's too rare. But if the APLS serologies were negative and the patient has hematuria, I would be intrigued. Thoughts on that, Prof. Reth?
Well, you closed your eyes when I gave you this. Now your eyes are open so you can see.
Woo!
I actually think that's brilliant, Robbie, because I was actually curious, like, what else would be lower in your differential diagnosis? Because if you never think about PNA, you'll never diagnose it. And just because you think about it doesn't mean you need to send the test for it. And this gives you also an opportunity to practice that illness script, because I can guarantee you that one of us, or in the YouTube community or on this chat, will eventually diagnose it because of that, spaced repetition that you just did. So I think that's such a beautiful lower tier diagnosis to consider. And thank you for sharing.
Amazing. Amazing. Let me just give you, I love the discussion. Let me just give you a bit more information. I have two more aliquots. So hemocool test was performed, which was positive. Serum calcium level, phosphate level, and PTH was normal. Peripheral blood smear was also looked at. It showed basically normal cell morphology of all cell lines, no schistocytes, no blasts, normal B12 and folate levels, and then they thought of and looked into figuring out, is this thrombophilia? So they actually found in the electronic health record of the patient that he already had the thrombophilia panel. So he does not have factor V Leiden disease or prothrombin G2O2AO. He has had at least normal protein C and S levels and normal antithrombin activity. I say this because if you were to measure it now under DOACs, it might lead to some false positive results. And by false positive results, we come to the antiphospholipid panel. So the lupus anticoagulant was positive, but again, this was tested under DOACs, which are known to create a false positive result. The anticardiolipin and beta-2 glycoprotein I was negative. Flow cytometry showed no absence of CD555 or CD59, ruling out PNH. On an SPEP, it showed an M spike, and the serum free light chains, there's a kappa to lambda ratio of 2.4. They performed a PET CT scan looking for anything, but it showed no abnormal focal FDG uptake. And the patient reported that he had these sort of episodes of thrombocytopenia, which always remained unexplained. And I'll stop there.
Thank you so much, Nicola. Just to clarify with how much I babble, do you have one more aliquot and then the diagnosis, or is this the time we have to
I
stretch?
have a bit more information for you.
Okay. Oh, thank
for the
God.
final.
Okay, good. Professor, maybe we can just dance on this and reflect together. I'll just take the monoclonal protein as the pertinent positive, and then maybe ask you to analyze the APLS serologies and everything else. I think that whenever somebody's over the age of 50, the probability that you find a monoclonal protein is 1% per year. And so you have to be careful because you could do this on a random stranger and get the same result. And so the question is this MGUS or is it something else? And the way you can help try to figure out if it's monoclonal gammopathy of uncertain significance is to study the M spike itself. So if the M spike is IgG and it's less than 1.5 grams per deciliter, it has a high probability of being uncertain significance, especially if the patient doesn't have any CRAB criteria. So this patient is already breaking that rule because his M spike is more than 1.5 grams per deciliter. So you have to take it seriously. And that's why the team obtained a PET CT scan and got additional testing. And thankfully, it doesn't seem to be related to a multiple myeloma or things of that nature, but it's why an investigation was performed. Now, I want you all to know that that investigation that was performed was only for one kind of complication from monoclonal proteins, which is quantitative complications, meaning that the monoclonal protein is representing an issue with the amount of number of cells that it's coming from and has malignant potential. However, a monoclonal protein can also result in what are called idiosyncratic complications, meaning these are complications that occur as a result of the configuration and the morphology of the protein. This essentially is the exact same conversation that we have with prion diseases. Most of the time when patients have a prion disease, they don't have a lot. It's just that the anatomical configuration of the prion triggers a lot of damage. And so that's the question we have to answer here. And that question has been unanswered because it's actually a very difficult one to answer. Is this monoclonal protein? Now we know it's not causing issues because of its quantity. There's not many plasma cells in the body that are doing this, but is it showing up because of its quality? And we can table that discussion until the end, but I think that's the key question now. I'm curious what you make of that, Prof. Raz, and what you're making of the APLS positivity.
Honestly, I think probably, at least in my DBX, in my small brain in the DBX I have, it can be one of two possibilities here. Either this is antiphospholipid syndrome, and that negative glycoprotein and cardiolipin does not dissuade me from it because you can have negative results. And I would probably take the person off of apixaban, put them on heparin or something else and then retest. Or are we dealing with like a myeloproliferative neoplasm? The only thing I don't like about that hypothesis is that oftentimes the cell lines are elevated. But when you get to the fibrotic stage, the cell lines go down. So bottom line is that I would get a hematologist involved. I would ask them, are we good with the diagnosis of APLS? Or do we have to do a bone marrow biopsy? Both because of the M spike and less likely because of a burnt out myeloproliferative neoplasm. So I don't know if we need to pursue an M spike, a bone marrow biopsy and ask for it, to be honest with you. I think this is where I have to rely on a colleague who has way more competence in this arena when it's not slam dunk for a specific diagnosis. What are your thoughts on that?
Yeah, Prof. Raz. Gosh, my thoughts are very complicated, honestly, because I'm very intrigued. Difficult. very difficult. I've seen so many people get that workup, Prof. Rez, and have to. Aaron Goodman, who I think we both admire and respect, has a powerful tutorial on when his dad was found to have a monoclonal M spike and the sheer amount of just burden that his dad anxiety was placed on, like following it, getting the bone marrow biopsy, and doing all that. And that was such a powerful tweet from probably the world's most famous educator in this space. But I think Prof. Rez here, a little bit of knowledge has me really worried about this patient. I think he has a very important disease that I can take a moment to outline. One is he definitely could have APLS. But I think whenever you find a monoclonal protein in this context, you should worry about a specific entity. And what I mean by this specific context, if you find a monoclonal protein plus thrombocytopenia plus clot, you need to worry about HIT, heparin-induced thrombocytopenia. And why am I saying that? Well, you might think appropriately that I have a delusion from, again, not sleeping at night, because the patient has received no heparin. And you would be right. And that's because the term heparin-induced thrombocytopenia is actually a specific entity under a larger umbrella called the platelet factor IV disorders. And so let me show you a picture. So these are disorders characterized by antibodies to platelet factor IV. And heparin is the most common trigger of these antibodies. We don't have that here. We learned from the COVID pandemic that vaccines can do the same. Remember this? Could the patient have spontaneous P factor IV? Yes. What's one very well described trigger? Right here. So, Prof. Rez, I think for me, if he didn't have thrombocytopenia, I would say I don't think the monoclonal protein is contributing to this clinical scenario. But I think the possibility of spontaneous platelet factor IV antibodies is a realistic possibility. And so I think I would probably investigate the monoclonal protein to its full length and would consider getting a bone marrow biopsy. But I think the most important test right now is to actually evaluate for anti-PF4 antibodies and to do the serotonin release assay to see if that condition is at play. Because if it is, it's a very, very aggressive, very, very serious condition. So in my mind, Prof. Rez, I'm treating this patient just like as if he's had a heparin exposure in the last week and has thrombocytopenia. Why? Because instead of the heparin, we have a monoclonal protein. What's your take on that? I don't. Do you think it's a little stretched too far, or what's your
Oh man, I am sold on sending you a lab test. And the truth of the matter is, like, if you go to that limited PDX of ultra hypercoagulable states, right beneath APLS, PNH, there's HIT. And so um, I wasn't familiar with MGUS as being a possible spontaneous trigger. That is very, very fascinating. And you wonder if his low-grade fever, not feeling well, if that was a stimulation to his immune system to create these antibodies and maybe causing a flare of the underlying disease. But no, I think that's really cool, man. I really don't have much to add, but it would be an eloquent explanation of everything, of everything.
Amazing discussion by both of you. Really kudos to both of you. And I have the final information for you guys. So first of all, just to sort of put a lid on the hemocold test, an EGD revealed a sort of non-described a new gastric ulcer, which was not actively bleeding, but was then presumed to be the culprit behind the positive hemocold test. Biopsy showed no malignant changes, H. pylori was negative, and it was attributed to his tobacco and alcohol consume. A colonoscopy was also unrevealing. And then to the PF4 ELISAs. So now I have a few really specific tests for you. So a PF4 ELISA, also called the HIT ELISA, which basically detects anti-PF4 to a polyanion complex, or heparin basically, was negative. But then there's also the PF4 WIT ELISA, which detects anti-PF4 without a complex, so without heparin. This one was positive. A serotonin release assay, which is basically a platelet activation assay, showed strong PF4 induced platelet activation without heparin. The patient actually denied any vaccination over the last several years, if not the last decade. And then mass spectrometry was performed, and on the kappa light chain of the isolated anti-PF4 IgG from the serum matched the kappa light chain of the M protein found in the peripheral blood. And this brings us to the final diagnosis of monoclonal gammopathy of thrombocytopenic significance and a potentially presumed gastric ulcer sort of in the background. Kudos to both of you. I'm just amazed because MGTS is a term which was coined in 2023, so just 2 years ago. Yeah, it's been I was fascinated by this case, and I hope you guys are too. I have some additional information. So he was actually then initiated on argatroband, bridging to potentially other Coumadin after that, because you really want to avoid all heparin exposures, including heparin flashes. He was started on IVIG, 1 gram per kilo for 2 days, with which the platelets actually rose to normal levels over the next 2 days. This is done to just sort of block the receptors on the platelets to prevent them to further clot and further cause thrombocytopenia. He was also initiated on daratumumab, bortezomib, dexamethasone to just suppress this clone. On bone marrow biopsy, which I didn't mention, he had less than 10% of clonal plasma cells, and with the monoclonal protein with less of 3.0 grams per deciliter, he falls under MGUS and not multiple myeloma. And I do have a few slides, but I know that we're over the time already, and Lira has amazing teaching points, so I think I'm gonna hand the mic to Lira.
I was so waiting for the slides.
Yeah, slides.
Okay,
We'll keep Prof. Rez here longer than that.
let me just share my screen. Just because it's such an intriguing case and there's such an intriguing pathophysiology behind it. I hope you can all see my screen, right? Yeah, so let's just dissect the PF4 diseases. So this is what usually happens, and let's zoom in on not our patient, but a normal person. You have your platelets circulating in your veins, and at some point they get activated. Potentially there's an endothelial disruption, and in order to stop the bleed, the platelets activate, they release PF4, and you can really think of PF4 as basically a glue. It just springs out of activated platelets and helps them to connect to each other, causing also other activation. It can also coat bacteria. So it's basically a pro-inflammatory and a pro-coagulatory protein. So this is how it normally works. And then you get a clot. Now, let's say you have an preformed antibody against the PF4, and you get heparin, which is sort of the black line. Heparin can then combine with the PF4, and if you have the antibody, you sort of cross-link the PF4 and the heparin, and you get HIT, which then links to the platelet, causing it to activate, causing thrombocytopenia, causing clots, and this is your HIT. But In HIT, then of course you get the thrombocytopenia, you get the VTEs. The HIT ELISA is going to be positive because you need the heparin to sort of cause the platelet activation. The VIT ELISA, which does not require heparin, is going to be negative. And the serotonin release assay, you're basically going to release serotonin out of your platelets only with heparin. And in contrast to that, you have MGTS or also VIT, so you can have MGUS in the background, or you can also have vaccines, or certain adenoviruses can also cause this. So if you have a monoclonal antibody against your PF4, it's going to latch onto your PF4, it's going to latch onto your platelets, and it's going to wreak chaos again, causing clots, causing thrombocytopenia, and the ELISA is going to be different now. So you don't need heparin anymore. You just need the PF4, and you're going to clot. And this is basically what the ELISAs and the serum serotonin release assay is going to turn out. And that's pretty much it. It's a very hot topic. It's very new. There's not that many there's diagnostic assays being made for it, and all our diagnostic assays are actually made for HIT. So these are just actually atypical results of the HIT assays, which can then sort of clue you into VIT or MGTS. Yeah, those are my slides.
Let me just say something. I feel like I know I'm the one who slept overnight, but I feel like I'm in a dream right now. You guys at CPS are just off the charts. That, like, I can't tell you how many words you just said, Nicola, that are brand new to my brain, but I appreciate it so much. And the animation, like, that was ridiculously good. Thank you so much for teaching me. Robbie, thank you so much for teaching me. You guys at CPS, I'm going to take myself out of that, are just psycho.
Prof. Rez, you're going to judge me, but I actually have a really nerdy question. And sorry to take up all your time, but I'm too curious, and I think some of you may be thinking of it. So, Nicola, when they do the HIT assay, in the presence of the monoclonal protein, why is the HIT assay negative? Does heparin stop the process from happening? Is that the idea? Or so if you were to ask me to make an educated guess on what the results would be in monoclonal gammopathy of thrombotic significance, then both the HIT assay and the other assay are both positive because it doesn't matter if heparin is there or not. Do you happen to know why the HIT ELISA is negative?
That's a super good question, and I have to confess I looked into it and I also didn't fully understand it. That's why I started making the PowerPoints. As far as I understand it, all the ELISAs are made for HIT and are gonna be really specific and sensitive for HIT, meaning that if you have HIT and you perform the HIT sort of standard ELISA, it's gonna be positive. If you have VIT or if you have MGTS, it's not always going to be positive.
I see.
And it's actually the combination of like this atypical results with the HIT, which can be negative, can be positive, with the VIT, which is going to be positive, and the serotonin release assay, which is also more complicated than my graphic. But yeah, it's a very complex topic, and it's really at the boundary of my knowledge, and I would have to look it up. So yeah.
Me too. I won't ask you any more questions, though. You've inspired so much reading and reflection for me. If I kept going, I think Prof. Rez would die of old age. So I will silence myself and end with quoting my mother and telling you that it's really cool what we're able to diagnose now. I mean, I think if you think about if this person suffered a horrible outcome, he, just like most of my family members, would be given a non-specific terminal diagnosis of old age, but instead he gets this like very precise like molecular label, and I think that's really, really cool. It's also really cool to be around you, Nicola, because I know you're at the cutting edge of this stuff in your research work. So thank you for bringing that case to us, and thanks, Prof. Rez, for dancing on a really cool heme journey. Hand the mic to Lyra to summarize the teaching.
Yeah, I really have no words after this session, so I'm gonna be very, very brief. And yeah, I just want to summarize and emphasize that when we have ultra hypercoagulable state, we really need to understand where is the central of gravity. Is it inside the vessels and in the clotting itself, or are there some extra clotting clues outside of the vessels? But when we search for the clues, we really need to be careful and understand, is this really a clue or is it a noise? Especially when we find things like monoclonal protein, we need to understand, is it just present due to old age, or is it causing any damage? And it can cause that not only by quantity, but also by quality. And here we need to look at things not only in isolation, but also in combinations. And when we have a really specific combination of monoclonal protein plus clotting problem plus thrombocytopenia, we really need to think about heparin-induced thrombocytopenia and the whole spectrum of platelet factor 4 disorders. So that's it. It's impossible to summarize the session, but thank you very much.
Is there a better teacher than Lyra? Like, so concise, so powerful. And I can't thank you enough, Lyra, because my tea time is going to happen soon. And you, out of Nicola and Robbie, the only person that is considerate of what my day looks like, which is this. But those two guys, they're so fascinated about medicine. Ooh, it's so interesting. I would never tee off. So thank you, Lyra. Say a word, Robbie.
Goodbye.